All right. Good afternoon, everyone. Thank you for joining us for First on the Scene Emergency Care Protocols for Hemophilia Patients. We are happy that each of you could join us for what we're very sure to be an informative and educational session. I am Gabrielle Gassaway, the Community Health Program Manager with Accessia Health, and I will be your moderator for today. Before we get started, I would like to cover a few housekeeping items. First, all lines are muted throughout the duration of the webinar. However, we welcome you to submit any questions through the event Q&A section on your screen. We'll have a time at the end of the presentation to answer your questions. For the convenience of some viewers and those who might be hearing impaired, closed captioning has been turned on. Also, the webinar is being recorded and will be available at accessiahealth.org. We'll also have polls later in the session and hope that you will participate as they pop up on your screen. Very briefly, I'd like to share a little bit about our organization. Accessia Health is a national nonprofit dedicated to addressing the needs of people with rare diseases and chronic conditions. We have a unique approach to traditional patient assistance that is holistic, inclusive, and outcomes focused. Our disease-based programs cover a variety of healthcare expenses, including copays, premiums, and travel. To learn more about our organization, please visit our website at accessiahealth.org. A very brief disclaimer here. Accessia Health webinars, events, and conferences are intended to provide information to the public. The views and opinions expressed by any speakers or third parties are not necessarily those of Accessia Health. I am very excited today to introduce our panelists. First, we have Dr. Samuel Pabón-Rivera from the University of Puerto Rico. He is a board-certified pediatrician and pediatric hematologist oncologist specializing in bleeding disorders and hematologic malignancies. We also have Dr. Leslie Soto, also from University of Puerto Rico. She is currently an associate professor at the University of Puerto Rico School of Medicine, Department of Pediatrics, Hematology Oncology Section. She is the director of the Comprehensive Hemophilia Treatment Center of Puerto Rico and also the director of the Puerto Rico Newborn Screening and Inherited Diseases Program. We also have Dr. Miguel Escobar from the University of Texas Health Science Center at Houston. He is a hematologist and tenured professor of internal medicine and pediatrics at the University of Texas Health Science Center, MD Anderson Cancer Center, and McGovern Medical School in Houston, Texas. He also serves as the director of the Gulf States Hemophilia and Thrombophilia Center. Without further ado, I will hand it over to Dr. Pabón to kick us off with an overview presentation.
Thank you, Gabrielle, and good afternoon, everyone. So these are my disclosures. As Gabrielle says, I'm Dr. Pabón-Rivera. I'm here in Puerto Rico, and I think we can go to the next slide. So we're going to be talking about hemophilia in the emergency department, pretty much. So what are the basics? And these are our objectives this afternoon. So we're going to be talking about, basic etiology, pathophysiology, and management of hemophilia A and B in the acute setting. We're going to review the treatment landscape in the current era. And we're also going to review the recent or the most recent MASAC guidelines for patients who have hemophilia. How do we manage them in the acute setting? And we're going to understand special considerations in the management of patients with hemophilia in the ED. And then by the end, we're just going to review a few cases with more interactive with questions. I think we can move to the next slide. So briefly, in summary, hemophilia, it's one of the most common severe inherited bleeding disorder. And now we know that we have, hemophilia A and hemophilia B, being hemophilia A the most common. And we know there's no racial or ethnic predilection. And then at the next slide, we're just going to talk a little bit more about the inheritance of this disease. So we know that hemophilia A or factor 8 deficiency, and we know hemophilia B as factor 9 deficiency. Both of them are due to mutations in the genes that it encodes for the factor. And it's X-linked recessive pattern, but we know there's about 30% of patients who has spontaneous or de novo mutations. It affects what is called the secondary hemostasis, or the portion of the coagulation cascade. And this is like a graphic presentation of how a healthy person with normal factor 8 and factor 9 production ended up with the clotting formation. And on the other graphic below, we see a person with hemophilia who has the X-linked affected. Those patients can either have a too little production of the protein or no production of the protein. And we're just going to review that in the next few slides. And the end product will be that the coagulation cascade will not work appropriately, and the patient will end up with bleeding symptoms. Nowadays, we know that has been recognized more and more often that females or heterozygous or carriers can be symptomatic. And most of them, they can express mild to moderate symptoms depending, how much factor they express. And this is more recognized in the past few years, because in the past, we tended to say that it was just a male unique condition, but now we know that females can also express this, and it's been more recognized recently. So we need to pay attention also for patients who have, family history or female that could be carriers. So I think we can move to the next slide. Next slides, please. So when we talk about hemophilia, so what lab findings we can see or what lab can show us some suspicion for hemophilia? Some patients with, the coagulation or basic coagulation profile, a PT and a PTT, we see that patients with hemophilia, they tend to prolong the PTT or the intrinsic pathway, because these are the blue ones on this graphic. When we have absence or little production of factor, the end up product of the coagulation cascade, fibrin, it's not going to happen. There's not enough thrombin formation. And when we test those patients, then the first step to do, it's just do basic coagulation profile. And we see the PTT is usually prolonged. And the next step when we are considering a patient with a diagnosis of hemophilia is to test the activity levels in the blood. And we know there's definitive diagnostic information about how the patient it's being categorized. We know that patients who have mild are usually between 5 to 40% of factor activity. Those patients who are moderate, they usually goes between 1 through 5. And those patients who are severe, they tend to have less than 1%. And those are the patients that usually can present with a spontaneous bleed. Patients who are mild to moderate, there's different phenotypes of the way the patients bleed, but those patients usually, they bleed with either trauma or surgery. And the most important thing is just to recognize that patients who have severe hemophilia A or B, they are more prone for spontaneous bleed. And this is another terminology or lab findings that we usually tend to assess the patient for those patients who are on factor prophylaxis or factor replacement. Those patients, when they get exposed to factor multiple times, those patients, they are at risk for developing inhibitors. And, how do we know, or when do we suspect when a patient could be developing an inhibitor in the ER setting or the ED setting? Let's say you have a patient that comes to the ED with active bleeding and you give them a dose of factor and the patient does not stop the bleed. So you have to think about inhibitor formation in patients who has been exposed to factor in the past. So that's one thing to consider and just to keep in mind whenever you see in patients in the acute setting. Just to consider. I think we can move to the next slide. So this is a graphic of the thrombin generation. So we see in gray a healthy person, a healthy control. They, have the thrombin that at the end ended up, cleaving fibrinogen to fibrin and forming a clot. Patients who have hemophilia A and hemophilia B, they do not make a big thrombin peak. So that's pretty much like just a basic information. I think we can move to the next slide. So hemophilia, it's a bleeding disorder. So the complications are going to be bleeding, right? And those patients, they can bleed in different locations. So patients can have bleeds in the joints or hematorosis. Patients can have bleeds in the muscles. Patients can have bleeds in the, in the brain, subdural hemorrhages. Patients can have pseudotumors in the abdominal cavity. Patients can have mucosal bleed, and patients can also have GI or gastrointestinal or GU bleed. So these are pretty much pictures of a patient with a big hematoma. When you see, hematomas like this, like out of proportion, you have to think about, possible hemophilia patients. And the other picture, we see a patient who had a dental trauma that bleed a lot after, factor administration. So this patient is not one of our patients. She just came after dental trauma after profuse bleed. And so we treated her with factor replacement. Next slide. So these also patterns of bleed, when you see a typical bruises like this, like very big, and locations are not typical. So you have to think about bleeding disorders such as hemophilia. Next slide. And this is a patient who has is our patient of us that has been suffering for chronic joint bleed or hematorosis. So those patients, the terminology is actually when they prone to bleed in a specific joint, that joint is called a target joint. And you see those patients who have chronic bleeding in the joints, they can develop chronic arthropathic changes. So that's why nowadays we're moving more to for prevention. So we're putting patients on prophylaxis to minimize the long-term consequences of patients that have usually multiple joint bleeds like this. Next slide. These are different images of patients who have had retroperitoneal bleed. So bleeds usually inside in the abdominal cavity, retroperitoneum after trauma. Mostly, when you see like the picture of the bleed inside the abdominal cavity. So we can go to the next slide with the arrows pointing. And also we see 2 arrows pointing to an intracranial hemorrhage after trauma. That's a brain bleed. So next slide. And these are trauma related. So we have this patient with hematoma bruise here, and then another patient with a mucosal bleed after dental extraction. Next slide. So when we review the treatment landscape nowadays, we are on a specific time of across the years where we have multiple treatment alternatives. And that's going to change the way we approach the patients in the next few years. Because when we look back in the 1950s, most of the patients that start getting plasma, they're in cryo. By this time, there were a lot of, patients who got a lot of blood-borne infections. And then the virus inactivations in the 80s minimized that, and then followed by first generation recombinant factor, more purified products that has been, developed across the year. And now we have a big repertoire of multiple products that we can use and we can offer the patients in the market. Recently in the 2025, there's, new and emerging products like called rebalancing agents that are going to be, part of the patient's treatment. So we need to recognize how to manage those patients in the ED when they come with these different products, because those products, they have also, labels, and you have to be cautious whenever you do treatment in the ED. And also, there's other alternatives such as mimetics. They usually are patients who have severe hemophilia that they're placed on mimetic agents to minimize the risk for spontaneous bleed. And now that prophylaxis has been recognized as a standard of care, we'll see more and more patients, on either factor therapy or mimetics or rebalancing agents for prevention of spontaneous bleeds. So we need to understand this better to offer a better treatment approach for those patients who come with the urgent care evaluation or emergency evaluation. So I think we can move to the next slide. This is just for review and just to give you basic information. What are the current FDA approved agents, factor product agents for hemophilia A? And as you see here, we have, different products depending on if they're plasma derived versus recombinant, standard half-life, and recombinant extended half-life. So what's the important point of this slide is just to give you the information of the half-life of the product. So there are going to be patients that are going to be on this type of products for bleeding prevention. And the patients, they have different regimens depending on the way that, the hematologists prescribe it and FDA package insert indication. So the most important thing is just to give you this information because there are products that actually have ultra extended half-life. So that means the half-life is going to be longer. So you always, whenever you see a patient who is on any of this product, it's always important to ask them when was the last time they got infused with the factors. So that'll kind of give you an idea, how we're going to manage that patient in the ED setting or the urgency care. And also down here is Hemophilia. That's one of the mimetic agents that has been used for patients with ranibizumab for prophylaxis in hemophilia A. And the next slide, it's actually what are the current products that we have for hemophilia B, pretty much, the half-life. It's what's going to be the major point on this because we have multiple products. And usually we have, whenever we pick which one are we going to use, it's a conversation with the patient and the family members, and they, usually pick what's going to be more beneficial for them. So always encourage for urgent care providers or emergency care providers to always look at the product the patient is currently in. And sometimes most of the patients who goes to an HTC, they tend to have like a clinic note, and we usually try to put on it an emergency care plan, either for minor or major trauma or surgery. So you can also get that information and guide you whenever you, manage those patients in the acute setting. Next slide. And we also have here the FDA approved medication or bypassing agents are usually mostly for patients who have inhibitors. Because for patients who have inhibitors, when the factor is not going to work appropriately, so you have to bypass the coagulation cascade. And here we have FIBA, or the prothrombin complex, and we also have recombinant factor 7. We have 2 products right now in the market that we can use. So depending which one you have in your pharmacy, so there's different indications for it. I think we can move to the next slide. And here is just like a diagram or a picture that shows where those factor replacement usually works, right? So we have indications for patients with hemophilia A without inhibitors. We have the standard and this extended half-life. And just like briefly to comment, because I know maybe some of you, I'm a pediatrician, but maybe some of you could be adult care providers. I know there's some centers that are doing gene therapy. I'll say for those patients, it's always good to have direct communication with the primary hematologist or the hematology team to guide you in the management of these patients. And then we also have, the mimetics. Right now in the market, it's only one of them approved, the emicizumab, Mim8 and NXT007 are currently in clinical trials. But, maybe in the next few years, we'll hear more from them. And, same concept with the hemophilia B. So you have the hemophilia B concentrate, factor concentrate. And for those who have inhibitors, hemophilia A or V, you can bypass with a factor 7 recombinant product. Next slide. So these are this information is pretty useful for all of you. If you go to the NBDF website, there are guidelines for the management of hemophilia in the emergency department. So this is a website for the NBDF When you can look specifically at the healthcare professionals, there's guidance on care, and then under that, there's one for emergency management. So you can click on that, and we can move to the next slide. And you will find out the MASAC guidelines. These are the most recent ones that we have. They're from 2019, and you can have specific information or basic information in the management of this patient population. Next slide. And just for basic information, let's say you have a patient with hemophilia A or hemophilia B. This is basic information about dosing. I'll say, let's say if you are in emergency or urgency care and you have to give that patient factor because it came with a head trauma, a basic knowledge is just to know that patients with hemophilia A who are going to get factor replacement, usually 1 unit per kilo in hemophilia A raises about 2% of factor in the plasma. In contrast to hemophilia B, it's a 1-to-1 replacement. So if, let's say you want to increase that patient plasma concentration of factor B to 100%, it's going to be, 1-to-1. In contrast to hemophilia A, 1 unit per kilo is going to raise you 2% in the plasma. Next slide. And basic information, whenever patients come to the emergency urgency, usually those patients should be triaged urgently, and we always should avoid delays in administering therapy because this can affect morbidity and mortality. If you can consult your hematologist, do it. But if you don't have any hematologist in-house, maybe you can contact someone from a close HTC to provide or give you recommendations. Administration of clotting factor replacement should not be delayed waiting for a consultation. So if that patient comes actively bleeding, or if that patient came with a brain trauma, with altered mental status, you should give the factor. Can we move to the next slide? And when we, suspect bleeding episode is usually or mostly based on clinical history. We know and we understand that patients who are on the early phases of most bleeding episodes, they might not present with symptoms until the bleeding continues to get worse. That's why it's highly important to, if you have highly suspicion of bleed, just to treat the patient with factor replacement. As I said before, spontaneous bleeding is usually more common in patients with severe disease and baseline factor less than 1%. And when you're in doubt, it's highly encouraged to administer clotting factor replacement immediately. If the patient or the parent suspects there's an occult bleed, you also should administer factor replacement immediately. Most of the time, patients are instructed to carry their own factor, but accidents happen. So maybe it was a car accident or a motor vehicle accident. So the patient might not have the factor with them at the time of the trauma. Next slide, please. So as I said, we also should not delay any factor replacement just waiting for imaging. So if the patient came with a trauma that is at high risk for bleeding, you should give them factor immediately, and then you assess with the images. Patients who have illness or are expected to have surgery, factor replacement or bypass treatment should target it mostly to 100% for major surgeries. But most of those factor replacement or agents, they have also guidelines for minor or major surgery. So I encourage you, and that's going to be maybe a job for the primary hematologist, but when you are in the ED or urgency care and there's something that you need to act quickly, I'll say just, try to bump that factor to 80 to 100% of factor correction. Next slide. And for individuals with known hemophilia, that they have a diagnosis of hemophilia, you don't need to do a lab workup, for coagulation labs like PT, PTT, factor levels at the time of the trauma. You just treat them. And because we know they have the disease and they have been diagnosed, they have been exposed to factors. So you should just treat them based on the trauma that they have. Should not be delayed by any cost, just waiting for results. Next slide. And these are based on the MASAC 2019 guidelines. These are pretty much the indications for factor replacement therapy. So when you have a patient that comes with suspected bleeding into a joint or muscle, any patient who had a significant injury to the head, neck, mouth, or eyes or evidence of bleeding in these areas, it's also an indication for factor replacement. Any new or unusual headache, mostly when they come after trauma, you should treat them with factor. Patients who who has hemophilia A or B with severe pain or swelling at any side, that's an early sign or sign of bleeding. Patients who have all open wounds requiring surgical closure, wound adhesive, or serous strips, those patients might need factor replacement. Patient who had a history of an accident or trauma that might result in internal bleed, you should give them factor. Patients who are planned to have an invasive procedure or surgery as well. Patients who have heavy or persistent bleeding from any side, GI bleed that leads to moderate to severe anemia also. And patients who have acute fractures, dislocation, or sprain also are indications for bleed. And of course, patients who or females who have been diagnosed as carriers who comes with heavy menstrual bleeding that leads to moderate to severe anemia or feeling stable, you should also give them factor as a mode of treatment in the ED or urgency care. This is just basic information that we have for you here, depending on the type of bleed. So we have two columns, hemophilia A and hemophilia B, and there's like two different practice patterns of dosing. So you can choose, you can choose or select which one are you going to treat your patient based on the clinical picture. But I'll say for patients who have intracranial bleed, we usually target from 80 to 100% factor correction. So, and for those patients who have severe or life-threatening bleeding, you always aim for the higher endpoint to minimize the bleeding from that trauma. And then you can see, different types of bleed when you look at the joint here, and then you look peak factor level. You can, select depending on the clinical picture of the patient. If that patient has a severe hemarthrosis, maybe you can target something from 40 to 60 factor replacement. And also it gives you like roughly the timing that patient might require therapy to control the bleed at the long term. And then we have different, and also all the different products, they also have the indications in the label for this. But for the acute setting, I'll say maybe focusing on patients with intracranial bleed, GI bleeds, trauma, or those patients who are requiring major surgery. These are the indications that we have to treat those patients in. Next slide. And very important treatment considerations now that we have this new products in the market. So for patients who are on the emicizumab or Hemlibra, those patients who are being treated with mimetics for prophylaxis, pretty much, there's information about avoiding prothrombin complex concentrate or FIVA because there's risk for thrombosis. And if you're going to do this, always have your hematologist by your side. But it's highly encouraged not to provide FIBA in patients with emicizumab at the moment. Those patients, they can receive factor replacement when they have a trauma or they're actively bleeding, because it's not, emicizumab is a mimetic, it's not factor 8 replacement, it's just mimics. So those patients can have a factor replacement for this type of trauma. Patients on factor prophylaxis, it's always highly important to know when the patient had the recent infusion, and also look at the half-life of the product. And if you are in a center where you can measure levels, that's going to be also very helpful. But if the patient is bleeding, I would say do not delay administration of factor, and just treat the patient. And as I said before, if the patient continues to bleed despite factor replacement, consider inhibitor formation and then possible different agents. Patients who are on rebalancing agents is our new products that were launched this year, 2025. There's also indication in the label and for depending on the bleeding type and surgeries. And we usually when we need to do factor, we try to do the least possible dose of factor replacement. So that's always good to have your hematologist by your side if you can. And then look for specific product guidelines. And for those patients who have inhibitor formations, so usually they have inhibitors, the factors not going to work. So those patients need an alternative replacement, and we consider recombinant factor 7 or prothrombic complex concentrate. Next slide. And I think that's the end from the basic information. Now we're going to move on to specific real life cases. And I think this is like the most exciting portion of the webinar. So you can interact with the poll questions. So we'll go through the cases, and Dr. Soto and Dr. Escobar are still going to join this session as well. So here we have a 6-year-old boy with severe hemophilia A who suffered head trauma from a fall at school. It was a witness report that another child was running, did not see him, and bumped into him, causing him to fall and hit the right frontal area of his head, directly in the concrete. When the emergency personnel arrived at the scene, the child has altered mental status, is drowsy, and complains of a headache. His mother arrives at the scene and has 1 dose of factor VIII with her. She's very nervous because the child does not recognize her, and she's unable to administer the medication. These are pictures that were taken after, so now we're just going to be focusing that we are, outside the hospital when the emergency personnel arrived. So I think we can move to the next slide, but we can see here that, on the CT scan, there's some findings of intracranial bleed. So what's going to be the most appropriate next step? I'm just going to give you a few seconds to answer this. It went away. Okay, so Dr. Soto and Dr. Escobar, what do you think about this?
Definitely the most important thing at this moment, because they have already available the factor, is to administer the factor. So if the EMTs at the scene, they can assist the mother to administer the factor dose. That is very important for this child with a head trauma.
Good.
Yeah, I fully agree. And I think you made it very clear, Dr. Pabón, that once you know the diagnosis and you have the product, you got to administer immediately. The emergency personnel and the ambulance is not going to have factor. But the fact that the mom has it, that is a very important thing. So they got to give it as soon as possible, because that could make a big difference in the outcome of this boy.
Correct. Thank you. And let's say the mom did not have the factor with her, at that time. So what's going to be the best next thing to do? So maybe getting him to the next or closest hospital that could have factor to the replacement.
Definitely. The most important thing is to administer him the factor as soon as possible. So if it's not available at the scene, and it's definitely it's not available at the ambulance, they have to take him to the closest center that have the treatment that the patient needs, because getting him to a center that does not have the treatment that he needs will delay more the treatment that is vital for him and his final outcome.
Great.
Yeah, and even if he gets to a place where they might have factor, you don't want to wait, like you already alluded to, for the CT or MRI, right? You got to give the factor immediately once they get there.
Correct.
No
Correct.
delays for any kind of studies or blood work. If you already know he has severe hemophilia, there's no need to repeat those studies. The mom already has a history, or maybe the history is in the hospital. And you got to do, first thing is first, which is treatment is the most important thing.
Great. Yeah, absolutely. I think you got into the right point. So every time we see a patient with hemophilia that we know he has a disease, you just treat them. If they have trauma, that's gonna translate into better outcomes in that patient. So good. Thanks. Next slide. So now, what is the appropriate target factor 8 level, and what is the approximate initial dose to administer in this trauma scenario? Let's target for a 30% or 50% or 80 to 100% or 10%. Great. I think most of the people got the right answer. What do you think, Dr. Escobar, Dr. Soto?
Yeah, I think, this is considered a severe bleed, right? And life-threatening. So absolutely getting to the higher, the better. Close to 100% should be the goal on this patient.
Right, correct. For most of the centers, in our center here, we have protocols or SOPs where the residents or the attending providers in the ED, they can, if they're in doubt, they can just look at those SOPs to look at the dosing, right? And that's going to be very helpful. For most patients who have a brain trauma, we went through, all that information. You would like to target 80 to 100% factor correction. And here, we see that's why, we dose that patient 40 to 50 units per kilo because it's hemophilia A. So that's going to raise about 2% of factor per unit per kilo. So that's why we picked that answer as the right one. Next slide. So here we have a 45-year-old gentleman with moderate hemophilia B was at his home in Ay Bonito, Puerto Rico, on a ladder trying to get onto the roof to clean it. He slipped and fell while climbing the ladder. He landed on his right elbow, which is his dominant arm. The elbow is painful, swollen, and has decreased range of motion. He has his factor 9 with him, but he's the only one who knows how to administer it. And the injured arm is his dominant arm, making it difficult for him to administer the treatment. And here we see the elbow with signs of bleeding and a hematoma on the side. Next slide. So what is the most appropriate next step in management for this patient? Are we going to encourage him to press and apply ice while he waits for the pain to subside? Are we going to attempt to do a joint aspiration to relieve swelling before administering factor 9? Are we going to assist him in administering factor 9 as soon as possible? Or are we going to admit him to the inpatient ward without giving factor 9? Great. What do you think, Dr. Soto, Dr. Escobar?
Yes, definitely this patient needs his factor dose as soon as possible so it can help him with that bleeding. So if you have persons in the area that are able to help him to administer the factor, it's very important to administer it.
Oh, I think some other measures are important as well, right? He'll probably need to keep the rest in that joint, and some ice will help too, but certainly is not the main treatment, which is the factor. And he needs to make sure that he's seen somebody later to do an x-ray, because we got to make sure he doesn't have a fracture of a bone there, because he had trauma, and that might change his management, going forward.
Very important points, yeah. And always good, that usually for most of the patients, we try to have them with factor ready at home. So that's going to be, maybe the first step when maybe an EMT or person who sees the patient first maybe can do the first approach with doing factor, and then we can also add all these measures, and that's really very important, as Dr. Escobar mentioned, all the other things are also part of the management, but factor replacement usually comes, first when this type of trauma to minimize the risk of bleeding, and then we also provide a supportive care for the patient to get better faster. Next slide. So this is a third case. So this is a 17-year-old male. He's in Humacao, Puerto Rico with some friends. This is a real case. riding a golf cart, and the cart flips over, and during the accident, his legs become trapped. When the emergency responders arrive, they find he has an open fracture of the right leg involving the tibia and fibula. At the scene, they notice he's wearing a medical colored bracelet, indicating he has mild hemophilia A. His mother arrives shortly after and says she has brought his factor 8. Next slide. What is the most appropriate next step in this case? Are we going to splint the leg and transport him to the hospital without administering factor 8? Are we going to administer factor 8 at the scene and then proceed with factor stabilization and transport? Are we going to delay factor 8 until imaging confirms internal bleeding? Or we're going to wait until arrival at the hospital for orthopedic evaluation before giving factor 8? This is a real case scenario that we had in our hospital. And what do you think, Dr. Soto, who saw this patient?
Yeah, in this case, because there is an open fracture, it's very important to administer factor as soon as possible, then stabilize the patient and transfer him to the hospital. In case the patient doesn't have the factor, like sometimes happens, then like stabilize patient immediately, take him to the adequate facility for the next care, and giving him the factor as soon as possible is very important.
Yes. And that's the thing, right? The patient has a factor, and it's a fracture, it's a trauma. So you should always get the factor first and then, move forward with the rest of the management. Next slide. So what is the appropriate target factor 8 level and appropriate approximate initial dose for this scenario? It's going to be a 30% factor 8 or 50% factor 8, 80 to 100, or 10% factor 8. Let's see. What do you think, Dr. Escobar, Dr. Soto, about this?
Yeah, I think knowing that it's an emergency and, he's got a fracture, so you got to get to a high level. So, it's a severe, I think, trauma. So definitely getting closer to 100 will be the ideal in this individual.
Good, good. And that's the main point, right? We have to recognize it's a major trauma. So whenever it's a major trauma, you just target a higher factor replacement level. Great.
And in this case, probably if patient, the dose that had and was administered at the scene was lower than that factor target that we want, we can redose at the hospital so we can get to that target factor level that we are trying to achieve.
Yeah, excellent point. Yeah.
Right. And even, let's say that patient is on prophylaxis, and let's say he had prophy the day before and his accident is today, you can still give him an additional dose. It's going to be fine.
Mm-hmm.
I know there was a question in the app asking, can you give too much factor? Certainly you can give too much, and if you get very high levels of factor 8 or factor 9, it can be dangerous. But in a case like this, you don't ask questions. You just go ahead and infuse him. Even if you infuse him that morning or the day before, it should be okay. A one-time increase in their levels is not really going to make a difference. It will be probably more beneficial than I think that will do him any damage.
Right. Yeah, I agree with both of you. Those are very important points, and just to keep them in mind, that's great. Good to know. Next slide. So we have a 15-year-old male known to have severe hemophilia A. He's on a weekly prophylaxis with Altuvio. So that's one of the extended half-life agents for prophylaxis. His last dose was administered 6 days ago. He's a competitive soccer player, and he was participating in a match earlier today. During the game, he collided with another player and later began to experience progressive abdominal pain. On evaluation by the EMS, he's noted to be hunched forward, guarding his abdomen. He denies external trauma or visible bleeding, but appears uncomfortable and pale. Can we just move to the next slide? So which imaging modality is most appropriate to confirm the and assess the extent of the bleed. It's going to be an abdominal ultrasound. It's going to be an uncontrast abdominal X-ray. It's going to be an contrast enhanced CT scan of the abdomen, or it's going to be an MRI of the abdomen. Oh, we have a mix answers here. So what do you think, Dr. Soto? Here people said 50% said an abdominal ultrasound, 13% says an X-ray of the abdomen, 25% pick an abdominal CT, and 13% pick MRI of the abdomen.
Definitely an X-ray will not be of any help at this point. If available, a trained personnel that can do a fast ultrasound, that can be done. However, because sometimes are intra-abdominal hematomas that can be in the retroperitoneum, it can be negative. Sometimes the ultrasound, and you will need a CT scan so that you can better access for the bleeding. MRI can also help, but sometimes it will depend on the institution that you are, if they are readily available, and it will take more time than the CT.
Yeah. What do you think, Dr. Escobar?
Yeah, I think, knowing that there was trauma, right? And the patient is pale, so he's symptomatic, probably losing blood. So you got to think of a few things, like Dr. Soto says, intra-abdominal hemorrhage, he could have ruptured his spleen, or he could have a retroperitoneal hematoma. So definitely this individual will need some sort of imaging, if you want to make a diagnosis. But, the important thing is to treat him as soon as possible. And, he might end up getting a contrast enhanced CT abdomen. But an ultrasound, if you have access to that, you can find blood in the abdomen, and you can make a diagnosis very quickly.
Yeah. Yeah. I mean, you're right. Sometimes, the CT scan is usually a faster option to get the patient into it, and we can detect blood. I mean, as you said, abdominal ultrasound is maybe not available everywhere. And it's usually, you have to, it's maybe could be a little bit painful for patients like this. So I'll say mostly an MRI usually takes too long. So I'll say contrast enhanced abdominal CT scan is going to be the best answer for this. And I think we can move to the next slide that shows that this patient, has been evaluated and had a retroperitoneal hemorrhage or hematoma with no signs of active external bleed. So vital signs are stable now, but it's concerning for internal hemorrhage. So can you move to the next slide? So at this moment, the most appropriate next step in management will be observe and monitor, administer an additional dose of factor VIII to raise the levels to 80 or 100%, delay factor VIII administration until imaging confirms active bleeding, or start oral pain medications and discharge home with close follow-up. Perfect. So I think you all guys got the right point. It's an emergency. Patient is having retroperitoneal hemorrhage. It's one of the it's a serious bleed. So the patient should get 80 to 100% factor correction despite he got factor acid prophylaxis. So I think we can move to the next slide for the sake of time. And this is our last case. It's a real case as well. So this is the mother of 2-day-old male newborn calls the PCP because the baby is still bleeding from the heel stick side, and despite applying pressure. She also mentions a family history of an older brother with severe hemophilia A. The PCP, recognizing the potential seriousness of the bleeding and family history, instructs the mother to take the baby immediately to the emergency department for urgent evaluation and management. Next slide. Which of the following should be the initial steps performed in the ED for this newborn? Should we perform a complete physical exam and order coagulation panel, including factor VIII levels? Should we reassure the mother that bleeding is normal after heel sticks in newborns and advise home observation? Should we apply topical hemostatic agents without blood test? Or are we going to discharge home the patient with instructions to avoid heel sticks in the future? Great. What do you think, Dr. Soto? People pick and Dr. Escobar perform complete physical exam and order a quark profile, including factor A levels.
Yeah, definitely that will be important also to ask if the patient already, because of the family history, he had the test done, so that we have already the diagnosis probably. But if he didn't have the diagnosis yet done as when he was born, and so we have to do the levels and also to give treatment to the patient probably, because if is only a heel stick, we can start with hemostatic agents locally and orally, and if that doesn't work, then we proceed with other treatments.
Yeah, I think it's very important, the history, right? So you got to ask the right questions to
Mm.
the family, to the mom. I've had cases like this, where somebody comes in an accident with a head bleed, and then one time I remember I asked the mom, anybody else in the family has history of bleeding? He said, yes, my brother. So I brought actually the brother to my center and did his levels, and turns out, that his nephew had hemophilia B. He was a mild, but only by asking the right questions, you're gonna be able to get to where you want.
Right. And I think that's gonna be it. And yes, so I think thank you all for your attention. And thank you, Dr. Soto, Dr. Escobar, for being part of this great discussion. Gabrielle.
Take it away. Thank you so much.
Yeah.
Firstly, I would like to thank all of you as panelists very quickly before we jump into the Q&A. This was amazing. I feel like we were all educated with like really in-depth information. Although I know this was a broad overview, I feel like I learned a lot. So thank you all. I have a couple of questions. I know Dr. Escobar saw this one in the Q&A already and answered the first part, which was, is there ever a concern of administering too much clotting factor? But the second part of that question was, how do you assess proper dosage if no one can provide context during the emergency regarding the patient's treatment or treatment schedule?
Yeah, I think that if you can measure levels, that'll be ideal, but sometimes you can't do that in an emergency setting, or the hospital doesn't have the capacity of doing factor levels right away. And usually the result will take at least an hour, if not more. So you can't rely on factor levels all the time. But if you can make at least an assessment on how much factor this patient has received, then you can get an idea maybe where his level could be at that point.
Yeah. Yeah, I'll say for the first time, when the patient comes with the acute setting, you just treat them and then you just like measure levels if you can. Because for most of, for big hospitals, yes, you can have maybe 24/7 access to factor levels. For most of the hospital, it's not available all the time. So and usually, not all the time, but for most of the emergencies, urgencies, it happens, anytime. And I'll say, as Dr. Escobar said, it's important just to treat the patient first, and then you can assess after the first approach is done.
Dr. Soto, did you have anything to add to that one?
I agree completely with them.
Okay. One other question. What is the best way for smaller clinics or critical access hospitals in rural areas to find the most up-to-date treatment protocols for those with hemophilia?
Yeah, I think it's important to find out, where the hemophilia treatment centers are. Every state has at least one. There are states that have multiple. So if you can find where those centers are and have a list, you can find them at the NBDF website. Then, if you have that list, you can always call those centers so they can send you maybe protocols or give you some guidance on how to treat that patient that came into your ER or urgent care.
Yeah. And as Dr. Escobar said, there's some places that maybe the HTC will be maybe 4 hours, 5 hours away from the patient or from you. And for there's some, for those who has some EMRs, and they can look at care everywhere and the patient has granted permission, maybe you can look at the hemophilia follow-up notes if that patient is currently seen on the same EMR. maybe you can also have a good idea what are the recommendations from the hematology standpoint for minor or major trauma, and maybe you can get some guidance from that. Because when I work in Texas for a few years, and I know that the system can help you find those little, or notes from the hematology that can guide you to provide an appropriate care and do the right dosing because, most of the places they're not seeing these very often. We see it because we are HTC, so we see most of our patients. For patients who are in the rural area, it's always good to maybe get access to that. And sometimes patients, they just carry with the hematology notes in their, with them.
Yeah,
What
no,
I
I agree. And it's important, to, at least we do in our center, we provide our patients with medical cards, laminated cards, with their diagnosis, their dosing, their disease, so they can show that, right? And if you have a medical alert bracelet, that really helps a lot sometimes for the EMS people.
Right.
And the emergency room. So it's important to do that. And always travel with your factor, no matter if you're going on vacation or you're going just for a regular trip for work. Always carry your factor with you. That is critical, because I think many patients have learned the hard way, where they go to small hospitals or they're in a small city and nobody has factor around that they can use.
That's very important here in Puerto Rico, that we don't have a connected EMR system. What I do is my patients have a letter similar to the one that we give to the patients when they travel, like with important information, especially if they are patients that are far away from our center, that it will take a lot of time getting here to the HTC center and to our ER, so they can go to the nearest center, to the nearest ER, and take their factor, and they can get assistance, and also have our telephone numbers so they can also reach us for any question or any guidance that they can need.
Okay, for the sake of time, I have one more question and then we'll wrap up. We are right at the end. Does travoprost or alpha-GAN P medication for glaucoma affect the blood clotting process?
Which medications?
Travoprost or alpha-GAN P?
I haven't used those medications. I haven't heard about that. I'm pediatrician. I don't know if you have any experience with that, Dr. Escobar.
Those medications, no, and usually medications for like glaucoma, I don't think it interferes. The ones that we are concerned about, some of the herbs or natural medicines or supplements.
Right.
Nowadays, we're seeing actually a lot of people using turmeric, and that certainly block your platelets. So you be a little bit careful when you want to try something new, especially just to buy over the counter. Talk to your hematologist. The other one is ginkgo biloba and ginseng. Those can affect your platelets too. And now a lot of people are taking the clover oil or clover concentrates. Those also block your platelets. So be a little bit careful, because they, in their websites or when they announce these medications or these drugs, they say they're good anti-inflammatories, and they might be good anti-inflammatories, but there are some things that you can't use when you got a bleeding disorder, because it will make things worse. So try to stay away from those type of natural products.
Great, thank you so much.
Thank you.
So I want to thank our panelists again for taking their time to share all of this great information and drive some very wonderful conversation. Your time is appreciated. I also want to thank all of our participants. We appreciate your time as well, and I hope that you learned something new today or something useful in your practice. We encourage you to complete the brief survey that you'll receive after the webinar ends. It helps us to make sure that we continue to provide helpful information and content. If you are not already doing so, please follow us on social media at Accessia Health to learn about other presentations and upcoming webinar series. And once again, I just want to thank everyone, and I look forward to hearing your feedback. Have a good afternoon.
All right, thank you.
Good afternoon.
Thank you.
Thank you.